The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Now let's discuss your cancer chemotherapeutic agents. So these agents, hindi siya gaano ka lumalabas sa boards. Siguro yung lumalabas lang mostly ay yung toxicities and side effects niya. So wag masyadong ma-stress sa chapter na to. So your cancer chemotherapeutic drugs, most of them act by damaging your DNA. Therefore, because it damages DNA, their toxicity is usually greatest at the S phase. So remember, S is for synthesis of DNA, which is the phase which cells undergo whenever they undergo division. So therefore, remember that human cancers, one of their hallmark features is rapid, uncontrolled proliferation and division. They spend a lot of time in the S phase, which is why they are very susceptible to chemotherapeutic agents. Pero at the same time, normal tissues that also undergo rapid proliferation, things like your bone marrow, which is why we have myelosuppression, things like your hair follicles, which is why we get alopecia, and things like your mucosal cells, which is why we get mucositis and mucosal ulcers. They are also very susceptible to damage because although they are normal tissue, the cancer chemotherapeutic agents only recognize rapidly dividing cells. So it also treats it as if cancer siya, therefore causing all the many side effects of cancer chemotherapy. Your chemotherapeutic agents can then be divided into your cell cycle non-specific or cell cycle specific. Pag sinabi nating cell cycle non-specific, they can act at any point in the cell cycle. So pwedeng G0, G1, S, etc. Therefore, they can target cells that are both dividing and non-dividing or quiescent cells in the G0 phase. So to review our cell cycle phases, remember that we have G1, wherein we synthesize the components needed for DNA synthesis. In the S phase, S for synthesis, we synthesize DNA by replicating the DNA genome. Then we have G2, where we synthesize the cellular components for mitosis. Then M phase, which is mitosis itself. Some cells who do not undergo cellular division undergo a quiescent phase or the G0 phase. So kapag cell cycle non-specific, kahit na G0 phase siya, hindi pa rin siya immune because we have cell cycle non-specific drugs. Whereas some drugs act on specific phases. So if it's cell cycle specific, as you can imagine, it will only target cells that are actively dividing. Because if it's in the G0 phase, it will not be able to exert its mechanism of action onto those cells. So again, we have cell cycle non-specific and cell cycle specific drugs. There are different ways to use cancer chemotherapy. You can use it as primary induction chemotherapy, especially for hematologic cancers, wherein it is the main treatment. Or we can use it as a palliative treatment in metastatic cancer. So we're no longer expecting disease remission. Instead, we just want to palliate or relieve some of the symptoms. We can give it as neoadjuvant chemo, meaning we give it before therapy like surgery in order to reduce the size of the tumor and make resection more effective. We can give adjuvant chemotherapy as well, which is when we give it after surgery in order to reduce recurrence and improve survival. Now, when it comes to chemotherapy and toxicities, we have the chemo man, which is something we draw again and again in order to remind us of the unique toxicities of these drugs. So si chemo man, syempre, kailangan may mukha, kailangan may tenga. Si carboplatin and si cisplatin. So meron din siyang katawan, kailangan may puso. And that's your doxorubicin, which is cardiotoxic. We have, of course, lungs na parang letter B, and those are your bleomycin because they cause pulmonary fibrosis. Kung may tenga, kailangan meron ring kidneys because your carboplatin and cisplatin are also nephrotoxic. Kung may kidneys, kailangan iihi. So CY looks like a urinary bladder because cyclophosphamide causes hemorrhagic cystitis. And letter V para sa kanyang kamay at paa because vincristine causes peripheral neuropathy. Okay? And itong nasa loob ng kanyang legs are just drugs that show you they are myelosuppressive. So your M for methotrexate, 5 for 5-fluorouracil, and 6 for 6-mercaptopurine. But again, most of these drugs are also myelosuppressive, not just these drugs in particular. Now, I mentioned that bleomycin causes pulmonary fibrosis, and there's a mnemonic we use to remember which drugs cause pulmonary fibrosis. Bleomycin, busulfan, bromocriptine, amiodarone, nitrofurantoid, and methotrexate, BAN-me. All of these drugs cause pulmonary fibrosis. Now, there are also rescue therapies for chemotherapeutic drugs kasi remember, they are toxic to both cancer and healthy cells. So let's say masyado ng severe ang kanyang toxicity, what can we give to reverse some of it? So for methotrexate, which is an antifolate, we give leucovorin, which is a folinic acid. And we start to give this whenever we notice severe mucositis and myelosuppression. Cyclophosphamide, like I said, looks like a bladder, CY. Causes hemorrhagic cystitis from a metabolite called acrolein. And so we give Mesna in these patients. Si doxorubicin, so si chemoman, may D for the heart, causes dilated cardiomyopathy, for which we give dexrazoxane. And cystatin causes nephrotoxicity, for which we give amifostine. So this figure shows the general mechanisms of actions of your cancer chemotherapeutic agents. So essentially everything from purine synthesis to the production of DNA to the transcription and translation of DNA, these chemotherapeutic drugs can act at different points. And I'll go through it quickly. So we have what we call anti-metabolites, meaning they prevent the metabolites that are used to produce DNA. So si purine synthesis, for example, pure as gold, adenine and guanine, we have two Trojan horses. I call them Trojan horses because they pretend to be a purine and they offer themselves for purine synthesis. Pero in reality, on the inside, they're actually cancer chemotherapeutic drugs. So when your DNA incorporates these toxic purines, the DNA then eventually is seen to be abnormal and the cell undergoes apoptosis or dies. So these are your 6-mercaptopurine and 6-thioguanine. So they inhibit purine ring biosynthesis and they inhibit DNA synthesis. Another example of how your chemotherapeutic drugs act is, for example, your alkylating agents. Kunwari, meron ka ng DNA and gusto mo nang i-transcribe and i-translate. Pero if you have alkylating agents which form adducts inside your DNA, DNA is not able to unwind, DNA is not able to be transcribed, and therefore the cell tries to kill itself or undergo apoptosis. So that is how your alkylating agents work. Or what if, for example, nagawa mo na yung proteins, the cancer cell has already made the proteins. You can inhibit things like microtubules, which are necessary for things like mitosis and the regular function of the cell. So these are your vinca alkaloids and your taxanes. So therefore, you would still exert a cytotoxic or a chemotherapeutic effect on these cancer cells. So just go back to this figure all the time whenever you want to study the effects of cancer chemotherapeutic agents. So your alkylating agents are cell cycle nonspecific. This is because they are inserted into the DNA of cancer cells. So even if the cancer cell is not actively dividing, if it's quiescent, for example, meron naman pa rin siyang DNA. So it can still act on the cancer cell. It also means that it is also toxic against non-dividing human normal cells. So it is inserted into the DNA of cancer cells. They form highly reactive intermediates leading to adducts, which is essentially just abnormal cross-linking of your DNA and eventual breakage. So the most susceptible site for cross-linking with these agents is the N7 atom of your guanine. And the most common side effect of all alkylating agents is your myelosuppression. So let's go through which one are your alkylating agents. First, you have your nitrogen mustards, your cyclophosphamide, ifosfamide. Again, they form DNA crosslinks, resulting in inhibition of DNA synthesis and function. They are cell cycle nonspecific, and they are particularly useful in the treatment of non-Hodgkin's lymphoma, and also in solid tumors of the children, especially your Wilms tumor. So siguro yun lang yung dalawang uses na kailangan yung i-remember. Again, the side effect, CUI, cyclophosphamide, looks like a bladder, is very severe hemorrhagic cystitis. So the hemorrhagic cystitis can be so bad that it can cause hemorrhagic shock and may even require a cystectomy or the removal of the bladder in order to stop the bleeding. So again, why do we get hemorrhagic cystitis? That is because cyclophosphamide is activated by CYP450 into 5-hydroxycyclophosphamide. Ito yung kanyang active form. Now, this unfortunately can also convert into aldophosphamide, and via the action of a non-enzymatic metabolism, you get acrolein, which is the cytotoxic metabolite. And it is also cytotoxic towards your bladder, therefore you get hemorrhagic cystitis. Again, our rescue agent here is Mesna and very, very aggressive hydration. So typically, patients who will receive cyclophosphamide get aggressive hydration even before the chemotherapy is started. Next, we have other alkylating agents, your procarbazine and your dacarbazine. So kung kanina si cyclophos used for non-Hodgkin's, ito naman ay more useful in Hodgkin lymphoma. Okay? So again, they are alkylating agents, so they cause DNA adducts, etc., etc. So their side effects are quite similar to all other chemotherapeutic drugs. They can cause bone marrow suppression, alopecia, gastrointestinal distress, etc. I'll just point out yung mga special side effects ng different drugs. Si procarbazine, it also acts as a weak MAO-I. So therefore, we cannot give it in patients who are taking serotonin, or rather, we have to stop serotonergic agents in patients who are receiving procarbazine kasi it can trigger serotonin syndrome. Furthermore, procarbazine has the highest carcinogenic potential amongst alkylating agents. Hindi ba ironic na it's an anti-cancer chemotherapeutic drug, but it is actually leukemogenic, meaning patients who receive procarbazine are at risk of eventually developing acute leukemia. The carbazine, again, very similar side effects to all the other drugs. Siguro ang special lang sa kanya ay it can cause a flu-like syndrome. Okay? Another alkylating agent is your busulfan. So it is another one of the agents that can cause pulmonary fibrosis. So B, bleomycin, and another B for busulfan. Its uses is in chronic myelogenous leukemia. However, it does have a side effect of myelosuppression, particularly very prolonged thrombocytopenia and adrenal insufficiency. So busulfan is so good at causing myelosuppression that we can even use it in patients who are about to receive a bone marrow transplant. Kasi diba, to receive a bone marrow transplant, we first have to ablate or eradicate all of our own bone marrow, and therefore busulfan is a good agent to use for this. Next, we have your carmustine and your lomustine, which are nitrous ureas. So must, okay? Same as previous mechanisms of action, which I discussed, they're alkylating agents. They are most useful in brain tumors, particularly your glioblastoma multiforme, which is a very, very rapidly progressive and very, very high mortality rate brain cancer. It is specifically designed for brain tumors because they are highly lipophilic and therefore they can cross the blood-brain barrier. So it makes sense that their toxicities are mostly concentrated in the central nervous system, like dizziness and ataxia. Again, they are highly lipophilic, allowing ease of passage through the blood-brain barrier. And the way I remember it is neurosurgeons can afford Mustangs and limos because carmustine and lomustine are used for brain cancers, which neurosurgeons try to treat. Next, we have your platinum analogs. So technically, hindi sila alkylating agents, but they have very similar pharmacological attributes as your alkylating agents. And you will remember them because they have plat in their name. Platin, cisplatin, carboplatin, oxaliplatin. Now, these platinum analogs form the foundation for head and neck, bladder, ovarian, lung, and colon cancers. Siguro, para hindi kayo ma-overwhelm, ang kailangan nyo lang i-remember ay they are really good for testicular and ovarian cancers. Okay, so your gonad cancers, testicular and ovarian cancers, give some of your platinum analogs. Okay, they are also nephrotoxic and ototoxic, like I said, diba? The C of the ears and the C of the kidneys. Now, the rescue therapy for the nephrotoxicity of cisplatin in particular is your amifostine. So the way I remember it is I have a cis named Amica. So cisplatin, amifostine. So how do we decrease the nephrotoxicity caused by cisplatin? We have to force diuresis. So it's forced diuresis. And we achieve this by giving mannitol with massive amounts of hydration. So medyo similar kay cyclophosphamide, where we give aggressive hydration in order to counteract the effects or the side effect of hemorrhagic cystitis. Now, carboplatin is an effective alternative agent for patients who cannot tolerate cisplatin because it is slightly less nephrotoxic. Okay, so cisplatin is more nephrotoxic than carboplatin. So, yung mga diniscuss natin na alkylating agents and platinum analogs, remember, they form adducts with your DNA. And therefore, they can affect cells that are dividing and non-dividing and are therefore cell cycle non-specific. Next, we'll move on to your natural product anti-cancer drugs. They're only called as such because they are derived from plants. All of them are cell cycle specific. So what are the cell cycle specific cancer chemotherapeutic agents? So first we have your vinca alkaloids. So they all start with the vincristine, vinblastine, vinorelbine. What they do is they bind to beta tubulin to prevent microtubule assembly and block mitosis. So therefore, they are specific to the M phase of the cell cycle. Why does it matter if we block microtubule assembly? Remember, during cellular division, the mitosis phase, kailangan natin mag-anaphase, metaphase, etc. The chromosomes need to line up in the center. They need to be pulled apart. And these are done via the action of your microtubules. So if you prevent microtubule formation, so here we have tubulin beta dimers, they are supposed to become microtubules via polymerization, and vinca alkaloids stop it. So it causes cell arrest at metaphase, and therefore the cells cannot proceed to divide. So this is the standard treatment for pediatric leukemias, lymphomas, and solid tumors. And in vincristine, it has quite limited myelosuppression, but it has very severe neurotoxicity, specifically peripheral neurotoxicity. So the mnemonic used here is vincristine crisps your nerves, okay? So it crisps your nerves. Whereas vinblastine, which has the same mechanism of action, blasts your bone marrow. So vincristine crisps your nerves, vinblastine blasts your bone marrow by causing such severe myelosuppression. So again, Christine crips the nerves, blastine blasts the bone marrow, and si vinorelbine is the Goldilocks of the vinca alkaloids. It is neither too neurotoxic or too myelosuppressive. Next, we have your taxane. So if you can inhibit the polymerization, you can also inhibit the depolymerization of your microtubules. So what this does is it actually stabilizes the tubulin GDP, causing arrest in mitosis. So what's the point of stabilizing the microtubules? Wouldn't that help the cell? Well, remember, we have to dissolve the microtubules after it does its function so that the cell can proceed to finish mitosis. However, if you prevent the depolymerization, it also causes arrest in mitosis and the cell cannot proceed with normal cell division. So its uses is mostly in metastatic cancer, more as a palliative therapy to reduce the size of the tumors. So these are your paclitaxel, docetaxel, cabizataxel. So kung kanina vin, ito naman tax. Next, we have your podophylotoxin, so your etoposide and your teniposide. So your etoposide and teniposide blocks your DNA topoisomerase 2, okay? And that is also called your DNA gyrase. Remember that your topoisomerase 2 is the enzyme responsible for cutting and religating double-stranded DNA, kaya siya 2 kasi double-stranded DNA. Versus your camptothecins, which are your topotecan, irinotecan, they inhibit topoisomerase 1. Si topoisomerase naman 1 is responsible for the cutting and religating of single-stranded DNA. So si topoisomerase 2, cutting and religating of double-stranded, kaya 2. Tapos si topoisomerase 1, cutting and religating of single-stranded DNA. Now, with both of these drugs, they are, again, cell cycle specific. Si etoposide and teniposide, S and G2 phases are particularly susceptible, whereas kay topotecan and irinotecan, si S phase ang particularly susceptible. So we can see them here on this figure na they block topoisomerase function, your camptothecins, and your etoposide and teniposide. Okay? Next, we have your antimetabolites. So again, they are like Trojan horses. They mimic your purine and their pyrimidines, pero once they are inserted into the DNA, they will cause chain termination and eventual cessation of your cancer cell growth. And because they target the building blocks of DNA, it therefore makes sense na S-phase specific sila lahat except for cladribine. So sino ba yung mga antimetabolites natin? We can either they are either folic acid analogs like your methotrexate, purine analogs like your 6-mercaptopurine, or your pyrimidine analogs like your 5-fluorouracil. So si methotrexate, this is one of your DMARDs as well, your disease-modifying anti-rheumatic drugs. What it does is it inhibits dihydrofolate reductase. And we know that dihydrofolate reductase is important in thymidylate synthesis. Kasi diba, to convert DUMP into DTMP, we need thymidylate synthase. And for thymidylate synthase to work, we need to convert dihydrofolate into tetrahydrofolate. And this is done via the action of DHF reductase. Okay? And so by inhibiting dihydrofolate reductase, we inhibit the production of tetrahydrofolate, and therefore DUMP cannot be converted into DTMP. And therefore, we decrease the synthesis of thymidylate. So it is very useful in choriocarcinoma, one of your trophoblastic diseases. So even in choriocarcinoma that presents with lung metastases, giving methotrexate can induce remission in those patients. Very important in childhood acute lymphoblastic leukemia, and it is given intrathecally as well in patients or in child patients who suffered from acute lymphoblastic leukemia, kasi the brain is one of the hiding spots of your leukemia cells. So in order to ensure remission, we give intrathecal methotrexate. Its non-neoplastic uses include rheumatoid arthritis, psoriasis, and of course, ectopic pregnancy. The side effects are myelosuppression and mucositis, and again, the rescue therapy is leucovorin, okay? Or folinic acid, kasi diba, it's a folic acid, it's an anti-folic acid drug, and so we have to give folinic acid in order to rescue or in order to give rescue therapy. Next, we have your purine analog, so 6-mercaptopurine, 6-thioguanine. Azathioprine naman, it's just the prodrug of 6-MP, so it is converted into 6-MP. Now, what happens is 6-MP is activated by your HGPRT into the toxic nucleotides that inhibit purine metabolism. So your HGPRT is your hypoxanthine guanine phosphoribosyl transferase. So it is useful also in acute leukemias. And I think the only thing I want to emphasize here is the metabolism of 6-mercaptopurine into its inactive form or inactive metabolite is done via xanthine oxidase. So remember, yung mga xanthine oxidase inhibitors natin in the treatment of gout. So when we give, for example, allopurinol and febuxostat, we can increase the toxicity of 6-mercaptopurine and azathioprine. So we can increase the risk of their side effects. So would giving febuxostat in someone taking 6-MP for leukemia increase or decrease its toxicity? So as we said, it will increase the toxicity. So kung merong purine analogs, meron ding pyrimidine analogs, and I'll just point out the important keys in this slide. So si 5-FU, okay, this is the drug that is activated into 5-DUMP. So it looks like your DUMP, which we know is used to convert into DTMP via thymidylate synthase. So dahil dito, it forms a complex with and inhibits thymidylate synthesis. Therefore, you have decreased production of DTMP, and therefore, you cannot proceed with DNA synthesis. So yung pinaka-important na lang siguro dito is that it can cause a side effect called hand-foot syndrome or palmoplantar erythrodysesthesia, which is tingling and painful symmetric erythema of your hands and feet. And the most common chemotherapeutic agents causing this are 5-FU, capecitabine, and doxorubicin. So imagine 5 fingers in a hand, 5-FU causes hand-foot syndrome or palmoplantar erythrodysesthesia. You have your cytarabine, which inhibits DNA synthesis by acting as a pyrimidine analog. Again, remember the Trojan horse analogy. Also used in your acute leukemias. However, one of its side effects is megaloblastic anemia. Okay, and cytarabine, cyta, can cause a lot of cytopenias. However, it is the single most effective agent for induction of remission in AML. So it's not the treatment for AML, but it will induce remission of AML. Si gemcitabine and capecitabine have the same mechanism of action as your cytarabine. And again, it can also cause the hand-foot syndrome, specifically your capecitabine, which I have discussed in this slide. Next, we have your anti-tumor antibiotics. So tunog antibiotics sila: actinomycin, bleomycin, mitomycin, doxorubicin, daunorubicin. So diba, they sound like antibiotics. So your doxorubicin and your daunorubicin, the letter D, what they do is they intercalate between base pairs of DNA to disrupt the normal structure of your DNA. They are therefore cell cycle nonspecific because they can attack the DNA of quiescent cells and also the DNA of actively dividing cells or actively replicating cells. So a very important must-know side effect of these drugs is they can cause cardiomyopathy. Particularly in the acute phase of their toxicity, they can cause what we call a pericarditis myocarditis syndrome, which presents as arrhythmia, congestive heart failure, and pericardial effusion. In the chronic phase of their toxicity, this is when they cause dilated cardiomyopathy. So high yield, it has to be dilated cardiomyopathy. It can also cause red color to urine. So I remember daunorubicin causes a ruby red urine. So what is the rescue agent for this? It is dexrazoxane. Okay, doxorubicin, daunorubicin, dexrazoxane. So this inhibits iron-mediated free radical generation because it is these free radicals that intercalates between base pairs and disrupts their normal structure. Next, we have your bleomycin and your mitomycin. Remember, si B, bleomycin and busulfan cause pulmonary fibrosis. Si D, the heart causes. Doxorubicin and daunorubicin cause your cardiomyopathy. So bleomycin and mitomycin also cause oxidative damage, causing single and double-stranded breaks, and they cause accumulation of cells in the G2 phase. They are particularly useful for germ cells of the testes and the ovary. And again, a very important side effect is your pulmonary fibrosis. Next, we have your actinomycin D or your dactinomycin. So, minove lang yung D to the start. The main use of dactinomycin, ito lang yung high yield sa kanya, is it's used in rhabdomyosarcoma and Wilms tumor in children. That's the only high yield thing you need to know about this drug. Rhabdomyosarcoma and Wilms tumor in children. So those are your general chemotherapeutic drugs. We now have newer chemotherapeutic drugs which are more targeted, and they are called your pathway-targeted anti-cancer therapies. Now, they can be divided into two classes. They can either be monoclonal antibodies, and you know they're monoclonal antibodies because they end with MAB, M-A-B, monoclonal antibodies. So they function as either blockers of cell receptors. They can recruit immune cells toward cancer cells, thereby promoting the killing of the cancer cells. Or we can also have small molecule inhibitors, which end in IBS or IBS. So these small molecule inhibitors actually enter the cancer cell to inhibit enzymes for cell growth and survival. And I'll show you how these drugs work. So let's start by discussing your tyrosine kinase inhibitors. So in particular, these drugs are used in the inhibition of your epidermal growth factor receptor pathway. So let's look at the figure on the left. Don't worry about all the many things on the slide. I'll point out the important ones. So this is your tyrosine kinase receptor. Remember that it has an extracellular component and an intracellular component. The intracellular component dimerizes, and this triggers several intracellular tyrosine kinase pathways like your JAK-STAT pathway, IP3-DAG pathway, etc., etc. So what these small molecule inhibitors do, like your imatinib, afatinib, erlotinib, geftinib, so they enter the cell and they inhibit the intrinsic or the intracellular tyrosine kinase activity. So therefore, the pathways are not activated because these pathways promote cell proliferation and cell survival. So by inhibiting that step, we inhibit cell proliferation and cell survival of your cancer cells. So, for example, imatinib and afatinib is very important in the treatment of your chronic myelogenous leukemia, particularly because they inhibit the tyrosine kinase activity of your BCR-ABL oncogene or your Philadelphia chromosome. It also inhibits the c-KIT tyrosine kinase in your GIST, or your gastrointestinal stromal tumors. So one of its side effects is fluid retention, so therefore it can cause congestive heart failure or cause decompensation of heart failure in patients who already have it. Erlotinib and gefitinib, again, just do the same thing where they inhibit EGFR tyrosine kinase activity, thereby inhibiting EGFR signaling. So it's very important, and epidermal growth factor is very important in the proliferation and the survival of your epidermal cells. So therefore, we can use it in cancers like non-small cell lung cancer and pancreatic cancer. So kung merong tyrosine kinase inhibitors, which are IBS or small molecule inhibitors, we also have monoclonal antibodies. And they naman act on the extracellular part of your tyrosine kinase, of your EGFR receptors. So they are monoclonal antibodies that bind to the EGFR and they inhibit downstream EGFR signaling. So therefore, they also inhibit cell proliferation and cell survival. So these are typically used in colorectal cancer, specifically your wild-type KRAS colorectal cancers. And that's pretty much the most high-yield part about cetuximab and panitumumab, okay? Next, we have your VEGF inhibitor. So your VEGF is your vascular endothelial growth factor inhibitor. So from the name itself, it promotes angiogenesis or the creation of new blood vessels. And the way I remember it is bevacizumab, BV, they inhibit blood vessel growth. So look at this. This is your bevacizumab, your monoclonal antibody, which binds to VEGF. preventing VEGF from binding to the VEGF receptor, leading to inhibition of tumor angiogenesis. Because remember, your tumor cells rapidly divide and therefore they need their own blood supply. So by cutting off their blood supply, we're also killing the tumors. So in addition to its use in metastatic cancers, it is also really important in wet age-related macular degeneration. So we know it is wet. This is a type of age-related macular degeneration that has angiogenesis or new formation of blood vessels in the macular area, thereby causing degeneration and visual loss. So this is injected intravitreally. So its side effects are things like hemorrhage, arterial thrombosis, and impaired wound healing because of its effects on inhibiting angiogenesis. Next, we have your CD20 inhibitor, rituximab, so rituximab. It's a monoclonal antibody against CD20, which is found on most of your B-cell neoplasms. So it can be used in non-Hodgkin lymphoma, but it can also be used in lupus or in your rheumatic diseases. However, one of the risks is the risk of developing PML or progressive multifocal leukoencephalopathy. So microcorrelate what is PML caused by. It is caused by your JC virus. So since rituximab weakens the immune system, it can make one prone to central nervous system infections such as your JC virus, which is the causative agent of PML. We also have anti-HER2, which is your Herceptin or trastuzumab. So it's a monoclonal antibody against HER2, which is a tyrosine kinase receptor. What it does is it is very useful in the treatment of HER2-positive breast cancer. So if a breast cancer has HER2 receptors, this is very useful. However, one of the side effects is dilated cardiomyopathy, similar to your doxorubicin and your daunorubicin. So Herceptin, the way to remember it is Herceptin. It causes dilated cardiomyopathy, and trastuzumab for HER2-positive breast cancer. Next, we have your ATRA or your all-trans-retinoic acid. So what it does is it allows DNA transcription and differentiation of your immature leukemic promyelocytes into mature granulocytes. So what happens kasi in acute promyelocytic leukemia is the promyelocytes are stuck. They are unable to differentiate into mature granulocytes. And these immature promyelocytes then proliferate rapidly and cause toxic effects. So the classic finding in pathology is your Auer rods. So remember, if you were to look at a blood smear of a patient with APML, you would find cells that contain Auer rods. And that is your sign that this is an APML patient or acute promyelocytic leukemic patient. So the side effects of giving all-trans-retinoic acid or your tretinoin is retinoic acid syndrome, which is exhibited by things like dyspnea, fever, weight gain, and peripheral edema. So remember that retinoic acid is actually your vitamin A. So it is the only vitamin that can cure cancer. And the way to treat retinoic acid syndrome is by giving dexamethasone. So let's answer a few questions in the treatment or in cancer chemotherapy. So a patient with recurrent gum bleeding has been investigated with a peripheral blood smear. It showed positive Auer rods. What is the most important medication to give? So remember, Auer rods is one of your pathologic finding in APML, and the treatment for APML is your ATRA, your all-trans-retinoic acid. A breast cancer patient is undergoing chemo with doxorubicin, cyclophosphamide, methotrexate, and fluorouracil. After several cycles, she experienced tachycardia, and investigations show cardiomegaly. Which drug is responsible for this? Cardiomegaly, remember si chemo man. Letter D for doxorubicin, which causes dilated cardiomyopathy. And that's it for your cancer chemotherapeutic drugs. Again, don't get too stressed by this chapter. Just try to remember the specific side effects, the special side effects, and don't forget your chemo man.